1. Wegovy and Zepbound, price drops and access challenges. 2. Major insurance changes for GLP-1 weight loss drugs, what patients need to know in 2025. 3. Why CVS Caremark dropped coverage of Eli Lilly's weight loss drug Zepbound in 2025. 4. How to get GLP-1 drugs covered by employer insurance cost and solutions. 1. Wegovy and Zepbound, price drops and access challenges. Imagine this, the cost of Wegovy and Zepbound, two of the most buzzed about obesity treatments, is finally dropping. But here's the catch, access to these life-changing drugs still feels like a lottery for many patients. Let's unpack why. For the average person without insurance, these medications still clock in at around $500 a month. That's a steep price tag, right? Even with insurance, coverage is a patchwork quilt. Some plans chip in, others barely scratch the surface, and many leave patients grappling with hundreds of dollars in monthly costs. As Dr. Beverly Chang, a New York-based physician and paid advisor to both Novo Nordisk and Eli Lilly, puts it, coverage is not the same as access. But here's where it gets controversial, even as drug makers tout lower prices, the reality is far murkier. Take Zepbound, which raked in $2.3 billion in U.S. sales just this past quarter. Wegovy isn't far behind, with 200,000 weekly prescriptions and $1.9 billion in sales. Yet, these figures don't tell the full story. For most Medicaid and Medicare beneficiaries, these drugs remain off-limits for obesity treatment. And even when coverage exists, it's often partial. Employers, too, are playing a role. Many large companies with 500-plus employees are starting to include these drugs in their benefits. But others are pulling back, worried about the long-term financial hit if employees stick with the medications indefinitely. Pharmacy benefit managers, PBMs, the middlemen in drug negotiations, are also picking sides. CVS Health, one of the nation's biggest PBMs, recently axed Zepbound from its national formulary in favor of Wegovy, a move that left doctors scrambling to adjust treatment plans for patients who preferred Zepbound for its gentler side effects. And this is the part most people miss, the rise of compounded, off-brand versions of these drugs. During a shortage, compounding pharmacies stepped in to fill the gap. But the FDA recently declared the shortage over, which should have ended that workaround. Except for one loophole, personalized doses are still allowed. Companies like Hims and Hers Health now offer customized, lower-cost semaglutide, the active ingredient in Wegovy, at $165 a month. But here's the rub, Eli Lilly is suing these companies, arguing that compounded drugs risk patient safety by using unregulated foreign ingredients. Hims, however, insists it vets all components to meet U.S. standards. So, what's next? Both drug makers are developing pill versions of their treatments, which could hit the market in the next year or two. That might finally drive down prices for the injectable versions. Dr. Courtney Younglove, a Kansas doctor, has already seen patients save 15% by ordering doses from Canadian pharmacies. She's optimistic, I think we're in the early stages of a price war. I have hope. But let's not gloss over the elephant in the room, at $500 a month, these drugs swallow up 14% of the average U.S. household's annual income. For many, affordability remains a distant dream. Do you think the market will eventually make these drugs accessible to all? Or will cost barriers persist? Share your thoughts in the comments, this is a debate that's far from over. The Associated Press Health and Science Department receives support from the Howard Hughes Medical Institute's Science and Educational Media Group. The AP is solely responsible for all content. 2. Major insurance changes for GLP-1 weight loss drugs, what patients need to know in 2025. Imagine this, you've finally found a treatment that works for managing your weight after years of struggling, only to have it abruptly yanked away by an insurance company. This is the reality many patients face as major changes loom over coverage for GLP-1 medications used in weight management. And here's where things get tricky. These shifts could leave millions of people scrambling to adjust their healthcare plans while grappling with both physical and emotional fallout. Take Tara Ikobaxi, for instance. Last week, she met with her doctor, not to discuss new treatments or celebrate progress but to navigate yet another roadblock created by health insurance policies. A recent update to her prescription benefits meant that the medication helping her manage her weight, a solution arrived at through painstaking trial and error, would no longer be covered. "I'm completely outraged," Ecobaxi said. "This isn't just stressful, it makes me furious." Starting Tuesday, CVS Caremark, one of the largest pharmacy benefit managers in the U.S., will exclude Eli Lilly's Zepbound from its list of covered drugs. Approved by the FDA in November 2023 for chronic weight management in adults with obesity or who are overweight, Zepbound has quickly become a game-changer for countless individuals. But CVS Caremark argues there's a rationale behind the decision. Patients can still access other, safe and effective, alternatives like Wegovy, made by Novo Nordisk, albeit ones that may not work as well for everyone. In a letter sent to patients using Zepbound back in May, CVS Caremark stated, "This change is happening because there's another medication available that might cost less." The message was clear: if you refill your current prescription on or after July 1, 2025, you'll have to foot the entire bill yourself. But here's the part most people miss: not all GLP-1 medications are interchangeable. While Wegovy remains covered under CVS Caremark's plans, along with a few other options generally considered less potent, doctors and patients alike emphasize that switching between these drugs isn't as simple as swapping one brand for another. Obesity is increasingly recognized as a chronic condition requiring personalized care, yet the science often clashes with rigid insurance rules. Dr. Tracy Svenyak, Director of Policy Strategy and Alliances at the Obesity Action Coalition, highlights this disconnect. "We don't treat obesity as the long-term chronic disease it is," she explains. Instead, society continues to look for quick fixes, ignoring the complex biology involved. If decision-makers fail to recognize obesity as a legitimate chronic illness, we end up with exclusionary policies or cumbersome hurdles that prevent people from accessing necessary care. And those hurdles aren't trivial. Dr. Jody Duche, an endocrinologist at Beth Israel Deaconess Medical Center and assistant professor at Harvard Medical School, points out how challenging it can be to tailor GLP-1 therapies to individual needs. Some patients experience severe side effects, like constipation, nausea, or pain, with one drug but not another. Switching medications disrupts their progress, creating stress and sometimes wasting doses of drugs that were already hard to come by during shortages. When announcements about coverage changes hit, my inbox floods with messages from panicked patients, Duche shares. They're doing everything right, sticking to their regimen, eating healthily, exercising, and suddenly they're forced to switch medications. It's incredibly disruptive. She adds that navigating insurance mandates eats into valuable time during appointments, leaving less room to focus on actual patient care. Adding fuel to the fire is another looming policy shift set to take effect next year. In January, BCBS Massachusetts will stop covering any GLP-1 drugs for obesity treatment altogether, reserving them solely for type 2 diabetes cases. David Merritt, Senior Vice President of External Affairs for the Blue Cross Blue Shield Association, defends the move, citing adherence challenges. "Last year, we found that roughly 60% of people don't stay on GLP-1s long enough to see meaningful results," he notes. Yet, despite improving adherence rates, questions remain about whether these expensive medications provide lasting value. Zepbound and Wegovy, though both FDA approved for obesity, differ significantly in efficacy and indications. Studies show that tirzepatide, the active ingredient in Zepbound, leads to greater weight loss compared to semaglutide, found in Wegovy. Plus, Zepbound boasts additional approvals, such as treating sleep apnea in obese patients. Side effects also vary, making one option more tolerable than the other for certain individuals. For those relying on Zepbound, filing an exception request post-coverage change might offer some hope, but the process is far from straightforward. Many feel abandoned, angry, and anxious about what lies ahead. Ecobaxi voices a sentiment echoed by many: "After jumping through hoops to prove I needed Zepbound, now they're taking it away mid-year. It feels discriminatory." Eli Lilly, however, is stepping in to help. Through Lilly Direct, a platform designed to streamline telehealth services and prescriptions, uninsured patients can purchase single-dose vials of Zepbound for $499 monthly starting July 7. Still, the burden falls heavily on patients already stretched thin financially and emotionally. So, what do you think? Should insurers prioritize cost savings over patient choice? Or does this debate reveal deeper biases surrounding obesity treatment? Share your thoughts below, we'd love to hear from you. 3. Why CVS Caremark dropped coverage of Eli Lilly's weight loss drug Zepbound in 2025. Imagine this, a groundbreaking weight loss drug suddenly becomes out of reach for patients who rely on it. But here's where it gets controversial. CVS Caremark, one of the US's top pharmacy benefit managers, PBMs, has decided to stop covering Eli Lilly's Zepbound, a medication that's been hailed as a game-changer in obesity treatment. The move isn't just about cost savings, it's a clash between healthcare priorities and financial realities that's sparking heated debates. And this is the part most people miss: the decision could force patients to switch medications mid-treatment, risking progress they've worked hard to achieve. Zepbound, the brand name for tirzepatide, was approved in 2023 for chronic weight management and has shown remarkable results in clinical trials, with users losing up to 25% of their body weight. Originally developed for type 2 diabetes, sold as Mounjaro, it's now a key player in the obesity treatment space. But CVS spokesperson Philip Blando argues that GLP-1 drugs like Zepbound are driving up plan costs with their egregiously high list prices. He claims removing coverage could save clients 10 to 15% annually on anti-obesity medications. However, critics argue that the real issue isn't the drugs themselves, it's the pricing strategies of manufacturers and the rebate systems controlled by PBMs. Dr. Christopher McGowan, a specialist in obesity medicine, calls this decision deeply disruptive. He warns that forcing patients to switch medications, even to alternatives that are still effective, can lead to weight regain, new side effects, or stalled progress. GLP-1 medications aren't interchangeable in practice, he explains. Switching mid-journey can undo months of hard work. This raises a critical question: should financial contracts between PBMs and drug makers shape clinical decisions? Eli Lilly, the drug's manufacturer, insists it's committed to patient access. The company offers discounted vials through its self-pay program, Lilly Direct, for around $500 per dose, excluding insurance. But some argue that this solution only helps a fraction of patients, leaving many vulnerable to coverage gaps. Meanwhile, pharmaceutical giants like Eli Lilly have criticized PBMs for taking too large a cut of drug profits, claiming the only way to lower prices is if intermediaries take less for themselves. So where do you stand? Is this a necessary step to control costs, or is it a betrayal of patients who finally found a treatment that works? Share your thoughts in the comments. Let's start a conversation about who's really to blame for the rising cost of life-changing medications. 4. How to get GLP-1 drugs covered by employer insurance cost and solutions. Did you know that access to groundbreaking anti-obesity medications like GLP-1 drugs is largely out of reach for most Americans? These innovative treatments are reshaping our approach to managing obesity and related cardiometabolic diseases, yet many individuals with health insurance find themselves without coverage for these vital medications. For some patients, the last resort has been to seek compounded drugs, substitutes that lack the safety assurances from the Food and Drug Administration, FDA. These products are manufactured mainly in Chinese chemical factories and do not meet the rigorous standards upheld by FDA-approved medications. However, even this subpar option is disappearing as the FDA has recently declared that brand-name GLP-1 drugs are no longer in short supply, leading to a ban on off-brand alternatives. This raises significant concerns about availability and safety. Recently, former President Trump drew attention to the issue by referring to GLP-1 medications disparagingly as the fat shot. He shared a striking comparison during a public address, noting how a friend in London mentioned that the cost of these drugs in the UK is around 1/10 of the prices in the United States. Here, the average monthly cost exceeds $1,000, while in England, it is approximately $150. This disparity highlights a critical issue in the U.S. healthcare landscape. At present, no legislative measures exist to mandate that pharmaceutical companies reduce their drug prices for the U.S. market. However, there is a feasible pathway for making these medications affordable for many Americans. Most health insurance in the U.S. is provided through employer-sponsored plans, which are funded by both employee and employer contributions. Unfortunately, very few of these plans offer coverage for weight loss treatments. However, if insurance policies were to include such coverage, they would need to incorporate these drugs into their budget, likely leading to increased premiums for everyone. Excess fat is a contributing factor to numerous cardiometabolic diseases, and GLP-1 drugs present an effective solution for reclaiming health. Enhancing access and affordability to these medications could yield significant public health benefits, especially considering that about 88% of Americans face metabolic health challenges. Reports indicate that more and more employees are expressing their desire to have access to GLP-1 medications, and many employers are keen to provide plans that includes this coverage. Interestingly, brand-name drug manufacturers have already hinted at how these treatments could become more affordable. They currently offer their medications directly to patients at a reduced price of roughly $500 per month. However, a significant hurdle remains: people whose health insurance covers a portion of the medication costs are not eligible for this lower price. Additionally, even at $500, many individuals still find these drugs financially out of reach. The opaque nature of drug pricing in the U.S. complicates matters further. Numerous intermediaries, like pharmacy benefit managers, take a share of the funds earmarked by health plans. Simplifying the pricing structure for GLP-1 drugs could enhance their accessibility. Presently, a drug that costs $1,000 can involve around $300 in rebates negotiated by pharmacy benefit managers, along with a $150 coupon from the manufacturer. The effective cost for patients often mirrors the reduced price of $500 that manufacturers offer directly to those without insurance coverage. Imagine a scenario where these rebates and coupons are eliminated, and manufacturers simply charge employer-sponsored health plans the same $500 rate they offer individual consumers. If employers could contribute a portion of this cost, say $300 per month, employees might find their out-of-pocket expenses more comparable to those in other countries. This approach would create a rebate-free, coupon-free system, ensuring reasonable cost sharing by employers. One has to wonder why the rebate system was ever established. Its primary purpose appears to have been to encourage pharmacy benefit managers to favor certain medications. In the case of GLP-1 drugs, which currently have only a couple of well-researched options, the reliance on rebates seems unnecessary. In fact, recent agreements between pharmacy benefit managers and drug manufacturers have prioritized profits over the best interests of patients, often choosing which medications to prefer based on business considerations rather than medical needs. Lowering the prices of these life-changing drugs could relieve one of the most frustrating elements of healthcare: the need for prior authorization. This time-consuming process forces doctors' offices to expend unnecessary resources trying to navigate around obstacles that limit the deployment of premium medications to patients who genuinely require them, even when their healthcare providers are convinced of their necessity. While GLP-1 medications are proven to be highly effective for many patients, they also come with potential risks. It is crucial that we defer to healthcare professionals to navigate these complexities with their patients, ensuring that they can weigh the risks against the advantages. To incentivize pharmaceutical companies to lower their prices and encourage employers to contribute to the costs of these essential medications, the Trump administration should follow the Biden administration's lead by agreeing to cover GLP-1s under Medicare. It's worth noting that this year Trump rolled back initiatives making it more difficult for Medicare and Medicaid to utilize these treatments for obesity. Although this plan might not make all drugs affordable in the U.S., increasing access to GLP-1 medications could set us on the right path toward addressing cardiometabolic diseases and boosting overall public health. David A. Kessler, a former FDA commissioner, is the author of Diet, Drugs, and Dopamine: The New Science of Achieving a Healthy Weight. What do you think about the pricing of GLP-1 drugs and their availability? Are we doing enough to ensure that these medications can help those in need? ***, let me know your thoughts in the comments.